Hello everyone, welcome to the channel. I am Dr. Jyoti Verma. This is the second class of Spinal Anesthesia series. What really happens after you inject a spinal? Why does touch return before pain? Why same dose of bupivacaine produces completely different block heights in two different patients? Watch till the end to get the answers. This class will cover mechanism of action of local anesthetic, site of the action of the drug, drug uptake and distribution. We will talk about differential sensory block and drug elimination. Mechanism of action. Local anesthetic has two components. One is lipophilic, one is hydrophilic. Both are connected through a hydrocarbon chain. The type of linkage decides the type of local anesthetic, ester or amide. So, the lipophilic end of the local anesthetic gives the anesthetic properties of the drug. So, what happens is local anesthetic enters the bilipid membrane and blocks the voltage gated sodium channels through the inner side, which inhibits the entry of sodium into the channel. As a result, nerve impulse conduction gets blocked. So all this happens reversibly. So local anesthetics act reversibly by blocking the voltage gated sodium channels and inhibiting the sodium current to flow inwards. This in result inhibits nerve impulse conduction. Talking about the site of action of the drug, the major site of action of the drug is spinal nerve roots and the dorsal root ganglion. So, if we compare spinal with epidural, the nerves in the subarachnoid space are not protected by dura or arachnoid mater. We can say they are more exposed. So, that is why spinal has a more profound block as compared to epidural. And that is why spinal nerves are more prone to damage. Talking about drug uptake. So, drug uptake depends on multiple factors. When you inject a drug, it takes only 5 seconds. But what happens to the drug in the next 30 to 40 minutes decides whether your spinal will be perfect or patchy or high or completely failed. So, drug uptake depends upon multiple factors. So, the first factor is drug mass. Drug mass, suppose we take 5 milligram of bupivacaine versus we take 10 milligram of bupivacaine. So, the patient with 10 milligram of bupivacaine will have earlier drug uptake as compared to 5 milligram bupivacaine. The next factor is CSF drug concentration. As you can see, if we give spinal versus epidural, in spinal the drug is directly injected into the CSF, whereas in epidural it diffuses with some time into the CSF. So, in spinal the drug uptake is early as the CSF drug concentration increases early. So, the drug uptake is fast in spinal as compared to epidural. The other factor which affects the drug uptake is contact surface area. Nerve fibers have surface area. The smaller the nerve fiber, the larger the surface area. The smaller nerves are easily blocked as the drug uptake in smaller nerves is faster. Lipid content also affects drug uptake. The more the myelination, the more is the uptake. If we talk about tissue vascular supply, drug uptake is directly proportional to tissue vascular supply. However, drug uptake is inversely proportional to the nerve root size. Smaller the nerve root size, earlier will be the drug uptake. If we talk about speed of the drug uptake, size is a major factor, and smaller the nerve fiber, higher will be the surface area and early will be the drug uptake. Degree of myelination also affects speed. Myelinated versus non-myelinated, myelinated fibers have early drug uptake as compared to non-myelinated. However, the size of the nerve fiber has a priority over myelination. Drug distribution. So, mainly the primary mechanism of drug distribution is diffusion. Diffusion is the primary mechanism by which drug gets distributed into the spinal cord. Next is the CSF circulation. CSF circulation is different in pediatrics versus elderly. As the turnover is higher in pediatric age group, the drug gets distributed early in pediatric age group and gets absorbed early. So, CSF circulation plays a role in drug distribution. Varicity of the drug affects drug distribution. So, we will discuss each of them. Diffusion. If we talk about diffusion, the blue arrows are for epidural drug. We have given a drug above the durameter and it gets spread in the capillary direction, caudal direction, circumferentially and towards the CSF into the subarachnoid space and towards the spinal cord. So, the blue represents the distribution of the drug from the epidural space. If we give a drug in the subarachnoid space, the drug travels capillary and caudal and towards the spinal cord to the nerve roots as well. Diffusion is the primary mechanism of drug distribution. Drug also reaches the deeper dorsal root ganglion by passing through the pia mater into the spaces of Virchow and Robin. Spaces of Virchow and Robin are just extensions of subarachnoid space in the spinal cord. Then we will talk about baricity, how baricity affects drug distribution. We can change the baricity of the drug by adding dextrose, making it hyperbaric, and by adding distilled saline or water to make it hypobaric. So, this is the normal curvature of the spine, and in this diagram, the drug is injected in a supine position. So, the hyperbaric drug follows the gravity and gets collected in the sacral and towards the thoracic concavity. So, in hypobaric, the drug goes against the gravity. As you can see, it gets collected here, and isobaric gets collected at the site of injection only. What is differential sensory block? Differential sensory block is the temporal blockade of autonomic, sensory and motor nerve fibers. So, there is different sensitivity of nerve fibers to the local anesthetic depending upon the myelination and size of the nerve fiber. That is why there is differential sensory blockade. So, the first fibers to go are autonomic. After autonomic, about 2 to 3 segments below autonomic goes the sensory, and followed by sensory goes the motor. So, we can remember this as ASM. Autonomic goes first, followed by sensory, autonomic goes first, followed by sensory, followed by motor. So, these are the nerve fibers and order of their blockade. We can remember this by a mnemonic BCA DBA. So, BCA DBA. Let us discuss this. B fibers are the first to go. They are preganglionic sympathetic fibers. They are minimally myelinated and of size 1 to 3 micrometers. BCA. So, next fibers to go are C fibers. They carry the sensation of cold. How do we check cold on the patient? We get a spirit swab and we can rub it on the patient's skin and see that the patient will feel cold or not. Followed by C fibers, we have A fibers, B, C, A, and in A we will have D, so delta fibers. A delta fibers are the next fibers to go. They carry the sensation of pin prick, pain. So, we can check with a blunt needle that the patient is having pain to the pin prick or not. So, after A delta fibers, we have D, B, A. Next fibers to go are A beta fibers. A beta fibers carry sensation of touch. They are also myelinated with 5 to 12 micrometers of diameter. So, A beta fibers are followed by A alpha fibers. A alpha fibers are the most resistant fibers to get blocked. They are myelinated and of a larger size, 12 to 20 micrometers. So, can you say which fiber will recover first? The last one to go comes first. So, the last one to go is A alpha fiber. It will come first, followed by A beta, followed by A delta. That is why touch recovers first compared to pain. So, the regression order is reverse. If we compare differential sensory block in spinal versus epidural, in spinal the differential sensory blockade is more profound, more intense, and with a difference of 1 to 2 intervertebral segments. So, the autonomic will be 1 to 2 intervertebral segment higher than the sensory, and sensory will be 1 to 2 intervertebral segment higher than the motor. In epidural, this is highly variable and it depends on the volume and concentration of the drug used, and there is a feature that motor sparing effect. Motor sparing effect is used in labor epidural. In labor epidural, we only need the sensory part to go. So, we give epidural and there is motor sparing effect and the patient can walk. Drug elimination. So, how drug concentration changes with time? So, drugs get eliminated with time. So, what happens is the CSF volume is inversely proportional to the time for block regression. So, more the CSF volume, less will be the time taken for block to disappear. So, drug elimination is a time consuming process and duration of block, the block we have given, depends on the rate of elimination of the drug, and rate of elimination of the drug is solely by vascular absorption. Solely by vascular absorption. So, duration of block depends upon rate of elimination of the drug. Earlier the drug gets eliminated, less will be the duration of block. One important point to remember here is that the extent of spinal anesthesia. So, the extent of spinal anesthesia governs rate of elimination and as well as duration of block. Let me give you an example. Suppose we have two patients. One is having a block height of T4 and another is having a block height of T10. So, the extent of spinal anesthesia is more in patient with T4 because the drug is distributed to a larger part of spinal cord in patient with T4 block height. So, the rate of elimination will be higher in a patient with T4 block height, and if this is compared with a patient with block height of T10, the rate of elimination will be slower because the distribution of the drug is in a smaller part of the spinal cord as compared to T4 patient. So, the extent of spinal anesthesia decides the rate of elimination of the drug, and more the extent of spinal anesthesia, more will be the rate of elimination of the drug and less will be the duration of block. If we discuss about more lipophilic drugs, more lipophilic the drug is, more it will bind to the epidural fat and delayed will be its distribution into the circulation. So, duration will increase as the lipophilicity of the drug increases. Hyperbaric drugs have shown shorter duration of block as compared to plain or isobaric drugs. Increased age decreases the hepatic enzyme activity, leading to decreased elimination. That is why in elderly we give less drug as the sensitivity also increases and the elimination decreases. So, drug dosage decreases to achieve the same block height. So, that's it. If this breakdown helped you, hit that like button and see you in the next one.